the unmistakable charm of skeletal third classes. Actors like Tom Cruise, Keira Knightley, and Ronald, who, unlike the first two I mentioned, is one of my patients. He specifically comes to the practice asking for a dramatic face change aside from straight teeth. Can you help him? Gosh, I hope Keira Knightley's mouth does not look like this in the inside. But whatever, Ronald is here with his anterior crossbite, and hopefully there is someone who can help him. You and a good surgeon. So, tooth 22 is ectopic, and the occlusion presents third-class molar relationship on both sides. The lower midline is shifted to the right due to his asymmetric mandible, and the third-class occlusion causes a bilateral crossbite. The lateral radiography shows you a deficiency in maxillary growth and an excessive length of the mandible, which has grown clockwise, as Ronald is hyperdivergent. If the patient has to undergo surgery, you don't have to be too precise in the cephalometric analysis, as the surgeon will take care of the wrong angles, fixing them with brute force. In this case, the surgeon decided to perform a surgically assisted rapid palatal expansion before the bimaxillary surgery. So, you follow Ronald into the surgery room, and right after the surgical procedure, you bond the palatal expander while he's still intubated, asleep. Immediately after bonding the palatal expander, you give 5 or 6 screw rounds, and then teach some of his family members to perform the rounds twice a day at home, in this case for 18 days. Well, you see the patient after a couple of weeks from the surgery, and you're quite impressed by the amount of space created. The expander has taken advantage of the surgical discontinuity of the palatal bone and the median suture, expanding it a lot. Oh, and that's important. You remember to secure the expander with the metal tie after the activations, in order to prevent too much relapse. As the central incisors, brought by the root fibers, relapse toward the midline, you can start to align the upper arch with the passive self-ligating technique. This will give you the chance to start the derotation of 22 right away. You will be impressed by the strain that the 013 cunei tie can be subjected to without being permanently deformed. Instead, the lower arch is already almost aligned, so you can just opt for a traditional bracket system which will not need any frenzy activations. As always, when a palatally displaced tooth is brought forward, it tends to acquire positive torque. And you know very well what to do in these cases. Just put the 22 bracket upside down to get the same tip but opposite torque. The excess of keratinized gingiva does not bother you at all. A little gingivectomy at the end of the treatment will do. Ronald is almost there. You did well in the sagittal decompensation of the patient, worsening his third class by using second class elastics. Actually, the fact that the patient still shows a bilateral cross bite after a surgical expansion is perfectly okay. The arch diameters on the plaster models in first class occlusion match very well, as the maxilla will be brought forward and the mandible will be reduced. Orthodontic decompensation before orthognathic surgery leads to a worse profile, as lower teeth come forward and upper teeth get behind. The patient gets more and more depressed as he asks himself, why is it getting worse and worse? But you don't let him despair for so long. The time has come for surgery. Of course, you know surgical patients have to extract all wisdom teeth at least 6 months before the surgical procedure. If you leave them during the surgery, the mandible's fracture may follow a wrong path, leading to the failure of the surgery. After being intubated, cut open, and sewn back up, the patient wakes up dying to see a new beautiful face at the mirror. Unfortunately, what he sees is just a swollen face with yellowish bruises. But, thank God, the sagittal movements of the two jaws have established a first-class occlusion and normalized the overjet, while the crossbite has been fixed thanks to this sagittal correction. In a few weeks, the hematomas disappear, and the only thing left to do is to refine the final position of the teeth. Here, you use a power chain to close the remaining spaces, as the occlusion has been correctly set in first class by the surgeon, and you wait for the right time for debonding. A few months after the surgery, it's all going well, but Ronald receives and accepts a job offer from abroad. You would have preferred to close all the upper spaces, but the patient is happy, and this is the most important thing. The midline deviation has been corrected. You have a first-class occlusion and a good overjet on every single tooth. The final radiographs show the sagittal changes and the osteosynthesis screws, which will keep the segments together as new bone is created to seal the gaps. One of the first things to do after orthognathic surgery is to retake the ID photo, as the patient has a different face now. He smiles as he looks at you in gratitude, and finally, it's over. And now, forward with the next patient.